Hello, everyone. Welcome to another Rafael Medina virtual morning report. We are very excited for today's session, which covers the topic of primary care slash endocrinology. And we have excellent educators with us, Dr. Leung and Dr. Manolas. And if you can introduce yourselves and introduce each other, that would be wonderful.
Hello, hello. Thank you for having me. So, like you said, my name is Melina. I'm introducing an absolutely wonderful educator, researcher, above all, human being who I know really well. But I'm also lucky because I get to call her my mentor and my former program director, Dr. Peggy Leung. She's currently the program director for the primary care track at New York Presbyterian Weill Cornell Internal Medicine Residency. And she also serves as one of the clinic directors at the Long Island City Federally Qualified Health Center, where she's definitely been a fierce advocate for community advocacy, equitable patient care. And as you will see throughout this session, she is a wealth of evidence-based knowledge. So I'm very lucky that I get to present this case with her today.
I really appreciate all those kind words. And I have the same to throw back at Melina. So Dr. Manolas, but we're going to be calling each other by our first names today. Again, lucky to have the privilege to get to work with her when she was a resident over at Weill Cornell New York Presbyterian. She, from the beginning, was an educator extraordinaire, coming in as an intern, really loving all those tasks. And we got to see her really rise and even use those skills in so many different spaces as the assistant chief resident when she was at Cornell. And now she gets, Montefiore is so lucky to have her as an endocrine fellow currently, and she's in her first year. Today, she was rushing from her inpatient consult to be able to join us here today. So extra appreciative of her ability to be able to join us today. So you're going to get to see some excellent teaching from her today. I'm very excited.
I can feel your passion like going through your words, and I'm sure everybody watching and listening can feel that too. Peggy and Melina, why should trainees go into primary care slash endocrinology?
Melina, maybe I'll take the primary care first because you have said primary care first. I don't even know where to begin because I love primary care, and I've always loved primary care, and I wanted to do primary care ever since the beginning of medical school. And I went into medical school wanting to be a primary care doctor. And I know that's not always the case. Primary care is not always described as the most sexy subspecialty or specialty out there. But for people who love to champion longitudinal relationships, who love to take care of people in the social context in which they live, recognize when patients are human, not just sometimes, but all the time, and really coming up with incredibly creative solutions to help people navigate through the healthcare system. Like, that's totally why I'm in primary care. I'm one of those silly people that, if I spend some time figuring out, I got this person, this thing by talking to that person and connecting to that person, that gives me total detective joy by navigating the system that way. But I also understand that the system is incredibly frustrating sometimes, and that can be a turnoff for primary care. But those are just a little bit of a couple of things that make me really excited about what I get to do, and I get to know people very well. But Melina, throw it back to you for endocrinology, why they should join endocrinology.
Yeah, I actually I switched into the primary care track at the end of my intern year. I was originally a categorical resident, and I kind of just missed that outpatient time, getting to see my patients in their regular everyday clothes and not in their hospital gowns. I really enjoyed that aspect and the continuity. And so I think that's a huge part of not only primary care, but also a lot of medicine subspecialties that are outpatient based. And that's why I really loved endocrinology. I felt like it was kind of primary care plus a little bit niche that I would be able to have while still feeling like I could follow patients over time because it's mostly chronic disease management. So endocrine is a great specialty if you're an intellectual person, if you like to see objective data that you can react to and make meaningful change, and then see those results via objective, either lab values, imaging, etc. And for the most part, we do tend to see our patients get better. So it's a really nice specialty in that way. But it's very similar to primary care, I will say.
Yeah, and I love that. And Peggy, I want to find me a primary care doctor who's passionate and gets joy out of going the extra mile. That sounds amazing. And Melina, thank you for humanizing patients and seeing them in their normal clothes is one of my favorite moments in the hospital stay inpatient, is watching them before discharge, getting into their normal clothes and becoming a human. And it's like very, very humanizing. I agree.
You have a
If
lot
you're
of great
ready, we
examples
can,
down in Emory.
yeah, I really do. If you're ready, we can start with the case.
Sounds good. Okay. So I'll start by introducing some of the basic kind of patient characteristics. So this is a man who's coming in with difficult to control high blood pressure. He's 47 years old. He's someone that we see in the clinic quite often. He's been feeling okay. He's in good spirits. He's happy in his life. He's not really checking his home blood pressures that often. But when he does, it's typically in the high 130s, as high as 140s, 150s, but never really below 130s systolic at home. He's using the same cuff at home to measure his blood pressure as the one that he brought into the clinic, where you checked it for accuracy. He also has a past medical history of just high cholesterol, currently not on a statin, and anxiety. His current medications are amlodipine, losartan, and hydrochlorothiazide. In terms of, let's see, his family history, he does have a family history in his father of a stroke at age 55. And then socially, largely negative. I mean, negative for alcohol, tobacco use, any sort of drug use, including any stimulants like amphetamines. He's not making any intentional changes to his diet necessarily, but he does know about lowering salt intake, as we all do. He walks outside for about 20 minutes several times a week, but it's pretty inconsistent. And then no allergies. You guys are typing super fast, but I'm going to go on and say that for his vitals in the office today, they're notable for a blood pressure of 152 over 84. His heart rate is 72. His respirate is 12. He's not in any respiratory distress. He's on 98% on room air, and his BMI is 24. And we'll kind of loop back to this later, but on the large, his exam is completely normal. There's really no abnormal findings whatsoever on his exam. And we did do a good primary care thing and repeat his blood pressure in the office and with a manual cuff, and it's 154 over 82.
Peggy, this is a presentation that I'm sure you see quite frequently. So would you guide us through your thought process and how you recommend us, like trainees, to think about this case?
Yeah, I think this is, you're absolutely right, a very seemingly straightforward standard case that we see routinely. Blood pressure is something that we always check when we come into clinic. And so when I hear this case, I start to think, well, what's the issue, right? We don't really get a sense of from the patient what they're really worried about. There's a couple of objective findings that I'm worried about, right? So vital signs being in the 150s, and then the home ambulatory blood pressure is correlating similarly, 130s, 140s. And so really the first thought that I have is, what of these numbers are actually abnormal? And so what am I listening? What is actually my blood pressure goal? And I think that you guys are probably familiar with all the big trials recently about what our blood pressure goal should be. And maybe there is no low to how low we can go, is what the data keeps on showing. So in my mind, a goal for a really otherwise healthy person should be under 130. And of course, we want them to be not symptomatic. And there's a couple of really great trials that highlight this. And so, it's something that, gets, maybe perhaps a bad rap in primary care. It's like, oh, you're just following guidelines. But we have to be very familiar with what went into creating those guidelines. So how did we even come to this 130 and over under 130 over 80? And so I start thinking about, well, I need to make sure I know where my data from the sprint back in 2015, who was in the inclusion criteria, what were the actual findings, and what were the actual results that make me think that 130 over 80 is actually appropriate for this particular person. So you kind of think back. Sprint was, they followed people for like 3 years or so. They had 2 groups, target 120 and 140, and to see which had better cardiovascular outcomes. And it was actually incredibly impressive because this one particular trial really changed a lot of the ACC/AHA blood pressure guidelines. So we saw that the people had significantly less cardiovascular, bad outcomes like heart attacks, strokes, if you were in the intensive group. So aiming around blood pressures of 120. And the good thing to remember, because I had a really great mentor of Dr. Byron Dunhamopoulos over at Cornell who loved NNT. So every time I see like research or I see trials, I actively convert findings into NNTs to make it more relatable for me. So sprints, the NNTs for doing, and that's number needed to treat. So how many people do I need to treat in order for me to see the outcome that was desired in that particular trial? NNTs are in the 60s, right? So whether that's fabulous or not fabulous, I'll leave that up to you. 60, anything under 100 in my mind is pretty good, but it's not like I need to treat 20 people with that blood pressure goal in order to bring them a little bit lower. So NNTs in the 60s, sprint, it was very influential. So something to keep in mind. More recently, there's a couple of other trials. So STEP in 2021, similar population, but out of China, also showed that intensive blood pressure, again, around 120, can reduce the amount of cardiovascular related death. And that NNT was around 90. So maybe a little less impressive. And then most recently, hot off the press, out of that AHA meeting, they presented the cardia data, or not cardia data, sorry, SPRI in 2000. So this year, which again, similarly showed reductions in, bad like heart outcomes with individuals with intensive lifestyle or intensive blood pressure goals. But that NNT was like in the 200, so I'm a little less impressed. But we have a lot of trials now that show that probably a lower is a little bit better, right? So that's where I'm thinking this person is not at goal. I know what reasons I have for setting someone at a particular goal, so then I move on from there. And then I also really appreciated how this, like, I'm going to say Melina, when they took care of this person, actually rechecked their blood pressure, like, and then also got the history that at some point they made sure that their home blood pressure monitor actually worked appropriately. So that's, it's practically can be very difficult in clinic, but so important. And there's so many different ways to repeat a blood pressure, and we have to make sure we're doing it appropriately. So things, imagine the last time if you've taken care of someone in the clinic and took their blood pressure, and what did they look like? I think half the time their back's not supported, they're sitting on the exam table, their feet's dangling in the air, right? And so those are all things that can make your blood pressure go up, so higher than it actually needs to be. So make sure when you are actually taking someone's blood pressure that they're seated, feet firmly planted on the floor, back is supported, arm is at the level of the heart, so we can actually approximate the pressures that we actually want. So that's one thing we want to make sure we do appropriately. And then there's actually a really cool thing to check, a cool website to check if people's blood pressure machines are actually FDA approved and validated, which I highly recommend for you guys to check out, www.validatebp.org. It has a list of all the blood pressure machines that are appropriate for use, because you'll see patients, go on Amazon and just buy, whatever blood pressure machine that's most affordable, right? Like Amazon, you can find some on for like $20-something, but they might not be validated. Or, unfortunately, they go to like, say, a drugstore and it's like $80 for a blood pressure monitor. And that can be very cost prohibitive for some people. So just another little strategy you can do to figure out, there's $20 machines that are also on the validatebp.org website for you to check out. And what's also really great about that history taking and presentation is that you were able to get home blood pressures. And home blood pressures are absolutely so important because we can figure out what type of hypertension it is. Is it just actually hypertension? Does this person have white coat hypertension where they're high in clinic but normal at home? Or do they have masked hypertension? Which is they are low in clinic but high at home. And the reason why I actually care about that is because white coat hypertension if left untreated, have the same outcomes as someone without blood pressure issues. So you don't need to treat white coat hypertension. And interestingly enough, masked hypertension, it's the opposite, right? Where because you're not treating blood pressures that are often high at home, they actually have worse cardiovascular outcomes in individuals with high blood pressure. So that's why ambulatory blood pressures are actually very helpful. And there's also multiple studies to show how ambulatory blood pressures are much more correlated with end organ disease damage. Things like LVH, or left ventricular hypertrophy, is more correlated with ambulatory blood pressures than with in-office blood pressures. So something to keep in mind about why we actually care about those individual differences, and why always, if you have a hypertensive person and you're precepting with me, you know I'm going to ask you about what is their pressure at home. So make sure you know that particular response if you ever come up by ways of New York City. And so after I think about, well, are the blood pressures accurately taken in clinic? Are the blood pressures accurately taken care of at home? Then I start thinking about, all the other things that go into management, right? So I heard great things about, lifestyle stuff was addressed, right? So does this person, maybe the person's not doing the exact perfect things around diet, but we all know it's incredibly hard. And I'm glad that they had the conversation. So we want to make sure that you go into that a little bit more if you have time, right? And oftentimes, a primary care visit might not just be one problem, but multiple problems. So it might take multiple visits before you get a better sense of that. But sodium intake is something that's also very important in lowering blood pressure. And also, it's kind of lovely that the AHA just happened and we're talking about this topic, because a lot of really cool things came out of that particular conference. So that there was a really interesting study about sodium intake where they had individuals that were relatively healthy. And I think that was Cardia, and that's why I was thinking about it earlier. But the Cardia trial, they had relatively healthy people, one group that was just normal 2,000 milligrams of sodium intake daily, and then another one that was 500 milligrams of salt in a day, which is kind of miserable, to be perfectly honest. But what they can see was that when they did take, like for that 1 week of just lowering salt intake, they were able to lower someone's blood pressure as effectively as one of the first line blood pressure agents, right? So it lowered about 7 millimeters of mercury in blood pressure. So eating less salt can be as effective as taking like one pill, right? So think about then the context of how we counsel. And again, what is even possible in the context of the patient's care. 500 milligrams of salt is a little bit cruel in my mind, but we know that there is clearly a direct effect. Sleep also has a big effect. And then of course, you guys got a chance to ask about activity level, which is very helpful too. Other things that I want to make sure we get a chance to talk about with the patient is like really what medications they are on, because that can really bring up someone's blood pressure if needed. I mean, if you're worried. So, NSAIDs, OCPs, steroids, the list goes on and on. So I always like to think, are we doing anything to the patient that's making this number higher? And we go through their med-rec lists, and I can go on and on also about why med-rec is the most important thing you need to do at every single visit. But then now I'm just prioritizing everything. And then I also really love the social history that you guys collected about, alcohol, because alcohol is also highly correlated with high blood pressure. Drug use, especially stimulant use like cocaine and amphetamines, also very highly correlated with high blood pressure. So all the life things, the med things, all of that plays a role in blood pressure. And then the next thing I think about when I see a high blood pressure is, like we went to the med list, well, what medications are they actually on? Are they on all the first line agents or not? And I think in this case, this person is on the 3 first line agents, right? So it looks like they're on a calcium channel blocker. They're already on a diuretic, so hydrochlorothiazide, and then also an ARB for losartan. So they're already on the first 3 first line agents, which is helpful because that goes into the definition of what resistant hypertension is. And the most recent definition by the ACCHA will tell you that you are on, your blood pressure is still not at your defined goal, and you're using 3 antihypertensive agents from different classes. And just so you guys get, again, a little epi context of how many people actually have resistant hypertension. It's quite a bit. It's about 12 to 18%. So in the double digits, how many people categorically will have resistant hypertension in the section as a whole. And yes, we are prioritizing 3 medications, but we also have to make sure that they're actually taking their medications. Some people that have been thrown in the resistant hypertension category was just not taking the medicines. And depending on which study you look at, it could be like 50 to 80% of hypertensive patients just not taking the medications as prescribed. So definitely, when we see a number, we don't just immediately respond to that number. We want to make sure that it's actually appropriately taken. And I've definitely been on that side of, oh, I know how to fix a number. Let's add this, and then let's add this, let's add this. And I definitely had one patient that I got up to 5 medicines before we're like, wait, what's going on? And then we're like, let's just take away 3 of them and see what happens. And their blood pressure was actually lower. So don't be so trigger happy about prescribing medicines, because oftentimes in a very busy clinical setting, we're very reactive. And sometimes it's nice to take a little bit of a pause. And the other part about resistant hypertension that I do want to emphasize is to make sure that, like, the reason why we care about making sure we bring down blood pressures for individuals with resistant hypertension is that they really just have much more poor outcomes. They have twice as much cardiovascular events as compared to individuals with fairly well controlled or just not even in the resistant hypertension category. So important, again, to make sure we identify these people appropriately so we can take care of their blood pressures appropriately. And that's probably where I'm thinking in terms of how I respond to a number. But when someone's in the resistant hypertension category, I start thinking, well, is this just hypertension or is there something else? And this is where I want to give a big shout out to clinical problem solvers, because I recommended this page to so many of our residents. I recommended them to look at the schemas that you guys have on the website itself. We just recommended someone to look at that last week when I was precepting for the secondary hypertension category. So you guys lay it out so clearly about what are the different categories to think about. So take a peek at that. But what I really like about that schema as a whole, and how do I think about frameworks, is that one, I probably loop, and probably more from the primary care mindset, I think about things probabilistically, right? So what is going to be the most common? What am I going to see most often? I'm not in a subspecialist clinic where someone did some workup previously, and so they ruled out some of the more common things. I really have to think about common things as a whole. And so there's a couple of things that come to mind for me when I think of poorly controlled, again, assuming that this person is taking their medications very regularly. Some of the common things I think about are, 1, kidneys, right? So is there actual parenchymal disease of the kidneys? Is there potentially renal artery stenosis? Because the one thing we need to also keep in mind is that CKD is both a cause and a complication of poorly controlled hypertension. The other crazy number to think about is 40% of people with CKD actually have resistant hypertension, right? So that's such a high number. And renal artery stenosis, so it could be from, atherosclerotic disease. I think maybe the step 3 question is often fibromuscular dysplasia. So in that particular category, about, again, 15-20% of people with resistant hypertension may have renal artery stenosis. So keeping those numbers in mind. Kidney disease is very high up on my list. Another one I think about is obstructive sleep apnea. And this surprised me so much when I heard about this particular number. If you think of, and okay, I'm just going to throw it out there. Think about your prevalence of obstructive sleep apnea in your resistant hypertension people. If you have to guess a number right now, sit with that number. And okay, hopefully you have a number in your mind. The prevalence of obstructive sleep apnea in someone with resistant hypertension is 70 to 90%. And isn't that nuts? Right? So 70-90% of people with resistant hypertension will have obstructive sleep apnea. So we should probably very proactively screen to see if they fall under the criteria to get a sleep study. So something to think about, because that number blew my mind the first time I looked it up. The other thing that is increasingly common, and seriously, every single year, I see more and more data come out around this, and it's primary aldosteronism. And so, originally they're like, oh, it's in the single digits, for people with primary hypertension. But again, every new studies, it's in the double digits now. So another good number, couple of good numbers to remember is it's about, 8 to 10% of people with primary hypertension probably actually have primary like aldosteronism or hyperaldosteronism. And then in individuals with confirmed resistant hypertension, it's about 20%. So something to keep in mind, those are the top three I think about: kidneys, obstructive sleep apnea, and then hyperaldo are the ones that I worry most about in thinking about what do I do next for someone with poorly controlled blood pressure, not yet at goal, already on 3 medications, so lumped in the resistant hypertension category. But I thought, since we have really another expert educator here with Melina, could you make, because the list of what could be endocrine related causes of secondary hypertension is also incredibly long and also incredibly common. Do you mind maybe sharing with us a few things that come to your mind when you were thinking about elevated blood pressures, resistant hypertension in the endocrine realm?
Yeah, so obviously when they come to me, they have a little bit of a more workup usually, but when we see resistant hypertension in a patient and we're going through an endocrine differential, we're usually thinking, of course, primary hyperaldo. Also, Cushing's disease is a cause of resistant hypertension, acromegaly even, and then more common things being common, thyroid disease. So hyperthyroidism can cause elevated blood pressure. Those are kind of the main things that come to mind. And that also links to a lot of the physical exam findings. So for example, like the person really doesn't have any clinical signs of Cushing's. More and more, we're considering Cushing's to be a clinical diagnosis. So if someone's not having clinical signs, like they don't have stria, they don't have fat pads, they don't have metabolic syndrome and obesity, there's really no reason to go chasing that tail as like the primary cause of resistant hypertension. But that's where the exam is important in these cases. Getting TFTs is obviously a pretty easy test to do in the primary care setting. So usually that's an easy thing to rule out as well. I think it's really important to highlight the primary hyperaldo because unfortunately less than 2% of people that are eligible to be tested for primary aldo are ever tested. And because of this, a lot of the time, by the time they come to us in the endocrine clinic, they already have very severe disease and severe comorbidities that are irreversible. Just this month on the inpatient service, I've had 3 patients less than 40 in their 30s who came in with strokes and were found to have primary hyperaldo that could have been potentially, cured with either an adrenalectomy or with medication, and they would have never had a debilitating stroke at this age. So that's why it's so important to think about.
Wow.
Thank you both. And I had a question. I know you mentioned diet and how that affects blood pressure. I was wondering if you routinely incorporate substituting salt for like potassium chloride, or that has not made it into like the guidelines yet. I know there was a study a few years ago in China that showed like some benefits. So I was just wondering what your practice is regarding diet and what you advise.
Yeah, there's so many salt substitutes out there. I think they are helpful. I think the ones used in the trials can sometimes be a little bit cost prohibitive, unfortunately. But I think it's more, I think where a lot of my patients are at in the primary care side is just awareness. And so we can even do a 24-hour diet recall, even go over like, well, where are you adding salt? Where are you getting takeout? What are those little substitutions that we can make? I think those are nice, easy steps to dive in. But that's something that I think for very few people I've suggested, but that could just be, how I've incorporated in my workflow, but hasn't fully been in, but it definitely is an option.
Thank you. Melina, I think we're back to you.
Sorry, there we go. Let me just kind of run back to, I know I mentioned that the exam was normal, but kind of going on to the labs and the imaging. So this is all kind of done in the primary care setting before any sort of referral is made. This patient had a BMP with a sodium of 142, a potassium of 3.3, chloride was 102, bicarb was 22, their creatinine was 1.2, their glucose was 114. They had normal TSH and free T4, so TSH was 2.1 and free T4 was 1.3. I know you have LFTs listed there. They were all normal. GFR was also actually in normal range. And then the primary care physician had started some workup for resistant hypertension. So they got a plasma renin assay that was 0.08 nanograms per milliliter per hour. Their plasma aldosterone was 18, where a normal reference range is usually around less than 15 nanogram per deciliter. Their serum metanephrines were normal, so completely normal range. And then their 8 a.m. cortisol after a 1 milligram dex suppression test was 1.6. So typically we say anything that's less than 1.8 after a dexamethasone suppression test is normal. So in this case, we would consider that to be a normal 8 a.m. cortisol. And then imaging wise, they had gotten a renal ultrasound that didn't show any renal artery stenosis. And then they had a CT abdomen pelvis from a year ago for a totally unrelated, like abdominal pain, gastroenteritis, ED visit that didn't show any abnormalities and had normal adrenal glands. So this is kind of, where I would turn it back to Peggy and say, is this a workup that you would actually send in your primary care clinic? And in this scenario, how would you interpret these results at this stage?
Yeah, I was just gonna say, I really love this person who's doing so many things, and it's totally possible, which is something that, I want to make sure we can emphasize, that it's not often too cost prohibitive. The fact that they got all these scans done, hopefully in a timely manner, might be the more difficult one. So, let's just start from the top. So if we look at the BMP, there's a couple of noticeable things. The K being 3.3 is one, so a little hypokalemic, makes me think, is this relating back to, hyperaldo? Creatinine being, borderline high, maybe, but normal GFR makes me think, probably less likely. And again, keeping in mind that that list of differential for secondary hypertension in mind, and that's what that's how I'm going through the results with that particular lens. So that 1.2, okay, something to maybe trend more than anything else. Glad there's some normal thyroids. I always get so confused about that silly ratio for when we're trying to work someone up for primary hyperaldo, because I think that scares a lot of people. Like, what's the right test? Because there's a bunch of different renin assays. Like, what is the actual aldo concentration? So what I often just clue into, I first look at, all right, what is the aldo number? If the aldo number is like very high, that is often good enough for me. At 18, it's not super, super high, but I'm getting a little bit more suspicious. When it's like in the above 20, above 30 realm, then that makes me, again, a little bit more suspicious. I see the renin assay was under 1. And so, again, it's just a clear division, right? So aldo over renin. And so, all right, that number gives me a ratio that's probably above, or around or above 20. So that makes me think, okay, it's a little bit higher. Plus I have the potassium that's low at 3.3. Again, makes me a little bit suspicious. The other thing to keep in mind about ordering aldosterone is that if someone has a low potassium, so under normal, that can actually reduce aldosterone secretion. So I'm thinking that the real aldo, if after we correct potassium, it's probably going to be a little bit higher. So again, hyperaldo is rising on my list right now. Serum metanephrines is often something that I will order because it's just a simple blood test. But it's so incredibly rare that it probably, if we're thinking about cost-effective ordering in clinic, and then because I do work at an FQHC, certain patients of mine that, let's say, don't have insurance and are self-pay, this is probably not something I'm ordering routinely unless it's very high on my list based on their presentation. The dexamethasone suppression test, which is what if you ordered an 8 a.m. cortisol, that is actually something I would actually do if they have the right clinical features for. It's not very hard. People think like, oh, it's a 2-step test, I'm never going to get it done. But it really is just one pill in the evening, and then they just have to come in at 8 o'clock in the morning for a blood draw, and then that's it. So you can perhaps time all the other extra tests for that particular AM lab draw, so then we don't have to poke a patient multiple times. So there's different ways to effectively do this that, again, we're thinking about. We're using our, our differential, and again, keeping in mind, we're thinking about the most highly probable things. And then that way we're ordering things that are most cost effective for our patients, especially if they don't have the means necessarily to pay for every individual cost to really satisfy whatever intellectual curiosity you may be. So that's how I think about the labs. The imaging, great. We ruled out, renal artery stenosis. And I love that the primary care doctor like dug deep to like, is there a CT abdomen pelvis from somewhere? You can often, like the last time I found an incidental adrenal adenoma was when a patient from their pain clinic got a CT of their spine. And this was something that they found an adrenal nodule that then we need to follow up. So there's a lot of adrenal nodules are often incidental findings, at least in my practice. I actually have no clue what the data behind that actually is. But I'm glad that, again, we are trying to use all the data that's available already in the system in order to figure out, well, what's the best next steps of care? So that's how I'm viewing this list, right? We still don't have a sleep study. Remember that crazy statistic that I threw out there? Primary hyperaldo is higher on my list, given the aldosterone concentration, the aldo over renin ratio, and then also the hypokalemia. So that's rising up on my list. And we ruled out a lot of really good things that were on the list of secondary hypertension already. So that's where I'm at. And so in thinking about what do I do next with this person, I really have to recognize what my boundaries of as a primary care provider versus an endocrine doctor and all the subsequent conversations that may be needed for someone who I'm thinking about this. Like, do I need to do confirmatory testing, which is much more for primary hyperaldo, which if they're cluing in yes for the screening, we maybe not should do. Then I'm sending them over to endo to really help facilitate that particular process. The other thing to keep in mind as we're sending people to subspecialists as a primary care doctor is really thinking about how resource intensive or resource rich your setting might be. Again, very lucky to live in New York City where, individuals who may not have insurance, may not necessarily have fully documented status, can actually get their hands on city insurance. So I can order all these crazy tests or expensive tests in that particular setting without costing the patient too much. And getting them to endo is also not hard, even for my patients without insurance, probably a little bit harder in the safety net system, but with like Medicaid, so our governmental insurance, and definitely with Medicare, pretty easy to get someone into endocrine clinic, depending on which health system you use. So I can get someone into endocrine probably within a couple of weeks. So we have some time. So if that's why I love ordering the screening stuff first. So by the time they get to the subspecialist, we already have something to work through, and they might repeat some of these tests because, like we said, maybe after correcting the hypokalemia, they'll repeat the aldo renin. And how do you come up with all the subsequent plans without really confirming? And then when we get them to endocrinology, they can do a couple more specialized testing and counseling. So then, this might be a good time. Melina, how would you take a peek at this data, and what would you be ordering if this person popped into your clinic?
Yeah, so I think someone actually brought this up earlier, but the reality is that you do not need to have hypokalemia in primary hyperaldo, and that's why sometimes I feel that it might be missed in primary care clinics and in screening in general. So that in this case, that would point towards that for sure. But just to reiterate the point that a normal potassium level should not like rule out primary aldo in your mind. So that's one thing that's definitely standing out to me. A suppressed renin that's less than 1 is a huge standout, even if the aldo is a little bit borderline. So that's something that definitely stands out to me. In endocrine, we love to repeat labs over and over and over again to make sure they're real if they weren't real the first time. So, my inclination would probably just to repeat them once more. Typically, we do that in these cases after the potassium has been treated. Like after the patient achieves normal kalemia, we'll sometimes give them a potassium supplement and then recheck those renin and aldo levels to see if those are real or not. Although in this case, I do feel like it's looking pretty real. And then to your point of the assays, I just want to make a point that, typically when you have an assay or look up, renin in an EPIC or an EMR, you'll typically see plasma renin assay, and then you'll see plasma renin concentration. So you'll see PRA and PRC. Plasma renin assay is more of a measure of the plasma renin activity, which is expresses the amount of basically enzymatic activity over time, whereas plasma renin concentration is expressed as like a mass of renin. And people always ask us like, which one's better? So they actually do correlate pretty well. So PRA and PRC do correlate pretty well. However, PRC, the mass, can be affected by estrogen status in women. So we tend to prefer PRA instead. So generally speaking, if you were to choose one, you should choose the plasma renin activity, the PRA. And that's mostly, I won't get into the weeds, but it's mostly because it measures the precursors or the renin substrate. So it measures angiotensinogen levels. So it's not as affected by, doesn't have as many false positives as a PRC does. I would also look at if this patient came to me, what other medications are there on? Because unfortunately, a lot of medications do interact with these assays and interact and affect the plasma aldo-renin ratios. So for example, spironolactone, eplerenone, high dose amiloride, those can falsely reduce the ARRs. Even beta blockers, clonidines, they can raise the aldosterone-renin ratio falsely. So in general, that's something to keep in mind. Ideally, in a perfect world, you would want to hold them for 2 to 4 weeks before checking these labs, as long as you think that it's a safe thing to do. But by and large, the medications are more likely to cause false negatives than to cause false positives. Other things to consider is, again, like salt intake, like Peggy had already mentioned. So a high salt intake at baseline would suppress the renin. Age also affects renin levels. So the older you are, the lower your GFR and your renal function. So renin levels also tend to decrease with time. Time of day, renin is highest in the early morning. Posture, they always say test renin and aldo when you're in an upright posture. So measuring these things in the hospital might be a little bit different than measuring them in the outpatient setting. So that's just something to keep in mind. But that's kind of what we think about. And in endocrine, our biggest principle is we always do biochemical diagnoses before imaging diagnoses. Sometimes the information comes in concurrently in this day and age, but ideally, we would definitely want to do biochemical confirmation with either repeat aldo and renin or further confirmatory testing before going and looking for some sort of adrenal adenoma or hyperplasia.
Thank you both so much. So I definitely feel more comfortable with all the tests we can check for hyperaldosteronism. I think no questions from my part. Yeah.
I was going to say, at this point, they had been referred to endocrine where a renin was repeated, and it was again found to be less than 1 after the patient had been on potassium supplementation and had gotten a normal potassium level, and the aldo was above 20. So again, that brought them to an aldo-renin ratio of over 20, which is obviously highly concerning for a primary aldosteronism. In this case, the next question in our mind would be, 1, does the patient need confirmatory testing or not? And 2, do they need some sort of medical treatment, or do they need surgical treatment, because that obviously changes next steps. In this case, the patient had a CT abdominal pelvis from about a year ago that showed normal adrenal glands. Typically, if we are going to look for something, we order CTs with adrenal protocol, because that gets us very thin slices through the adrenals where you're better able to see either hyperplasia or a smaller adrenal nodule to evaluate further. In this case, the patient did receive a CT with adrenal protocol that showed some bilateral adrenal hyperplasia. They were referred for adrenal venous sampling where no lateralization occurred, meaning that there wasn't a clear side that was a dominant secretion of aldosterone. And so medical therapy ended up being the treatment of choice in this patient rather than surgery with adrenalectomy. And the patient was started on spironolactone, where their BPs very rapidly, in a matter of about a month or so, went down to the 120s. Unfortunately, because this was a male, he did develop gynecomastia from his spironolactone. So then the primary care and the endocrinologists were tasked with getting a prior authorization for eplerenone, which is less likely to cause gynecomastia, but often is a little bit more difficult to get. And once he was switched, he did pretty well, and his BPs have been at goal. His hypokalemia has resolved. So that's kind of how this case in particular turned out, which wrapped up kind of nicely, but I'll say that it doesn't always end so nicely, kind of alluding to some of the patients I have in the inpatient setting right now, where they are, struggling with poorly controlled hypertension and the consequences of that, including stroke, metabolic syndrome, et cetera. And something I didn't know before I, came to fellowship was that primary aldosteronism is actually an independent risk factor for cardiometabolic and cardiovascular morbidity and mortality. So if you put head-to-head patients that have really poorly controlled blood pressure like this, 150s up to 170s, but no primary aldo, and then patients that have same blood pressure but primary hyperaldo, the aldo patients have much worse outcomes. So that's why it's so important to catch early. And there's two bottlenecks, generally speaking, from a primary care perspective and an endocrine perspective. And I think the first bottleneck is getting the endocrine appointment, because it definitely depends where you are, how soon that can come into play. And number two is whether or not they need adrenal venous sampling, because AVS, unfortunately, is something that's a very technical procedure that only certain number of interventional radiologists really in the city. For example, in New York City, there's only a handful of people that do it. So for example, I work at Montefiore and I work at Jacobi Medical Center as part of that, but I have to refer to Bellevue most of the time because that's, where the AVS specialist is. And they're hard to come by, and it's not something that every IR doctor or proceduralist is trained to do. So that's something that unfortunately also prevents and delays people from treatment.
And Melina, if the scan lateralizes on sampling, does that tell you that they might be a better candidate for surgery, or how does that help you in your treatment plan?
Yeah, so this is kind of where it gets into like the nitty gritty. So basically, in this case, so I'll kind of take you through this case and then take you through other options. So if the renin is suppressed and the patient is able to get surgery, meaning that they're a good surgical candidate, they're not like, they're mobile, they're kind of functional at baseline, and they don't have enough comorbidities that would prevent them from getting surgery, then you kind of think about what's the aldosterone level. If the aldosterone level is greater than 20, as it is in this case, then you don't need confirmatory testing. So you don't need to do all this crazy things like give them salt load and do saline suppression testing, which is very cumbersome and definitely something that endocrine would do. But even for us, it's very difficult. It's very, patients have to eat 6 grams of salt a day and then collect their urine for 24 hours. And you can't even imagine how complicated that is for the patient. And not to mention, in some cases, dangerous to take in that much salt when your blood pressure is already high. So anyway, so if the aldo is over 20, the renin is suppressed, then you don't need confirmatory testing. What you do next is you get the CAT scan and you refer for adrenal venous sampling. So if it does lateralize on adrenal venous sampling, meaning that the majority of the aldosterone is being secreted from one adrenal gland, then they would benefit, or the treatment really is adrenalectomy. So unilateral adrenalectomy of that one, adrenal gland that's hypersecretory. If they're not lateralized, like in this case, where both adrenal glands kind of either both secreting or it's not like one is dominant over the other, then we typically just put them on mineralocorticoid antagonist therapy, and that's their treatment. With that being said, I think someone had brought up the question of, what if AVS is not accessible? Like, what if I'm not in a city where that's accessible, or there's a huge bottleneck and who knows if they'll ever make it? In those cases, we typically say that treatment with MRA, like a spironolactone, is definitely better than nothing. So you might as well put the patient on that and get their blood pressure controlled instead of waiting 6 months to a year for them to eventually get some sort of AVS.
Thank you so much. And Peggy, if you were to give like the trainees listening 1 or 2 teaching points from this case, what would you say? What would you choose?
Yeah, I think one, that there's so many layers to a blood pressure number. So make sure we have all the basics down, right? Are we taking the blood pressure accurately? Did we get a good sense of what the person's, again, social context and how they live through their disease process and what's happening at home? Those are the first places we start. And then the next place is, am I thinking about this appropriately, and am I not just fixing a number, right? So there always has to be a goal in mind. And so is the person at goal because I want them to be at this particular goal? And then when do I actually have to start proactively thinking about resistant hypertension, thinking about the secondary hypertension? Because just like we had talked about, like the numbers today, like primary hyperaldo, and just happening primary hyperaldo in this particular case, which is like fairly common. But yeah, it could be, we're not aggressively controlling their renal disease. Maybe we're dealing with undiagnosed, sleep apnea. So I would say, make sure we have all the basics right, that we actually got a good blood pressure. And then we have to make sure that we're actively thinking about correcting disease, not just addressing a number that we're seeing in clinic. So that would be my 2 takeaways from the primary care side. But I would also love to hear what Melina's big takeaways from the endocrine side would be too.
Yeah, I think I do have a selection bias because I see it more than I did in residency, but I think it's also a bias because I think there's so much undiagnosed primary aldo out there that we're just not testing for enough. And so I really, really urge people who see patients that are on multiple blood pressure agents, instead of reflexively adding another one or saying, oh, they're non-adherent to their blood pressure medications, thinking about maybe an underlying etiology that kind of ties everything together. Because it is such a highly prevalent disease, and it's something that unfortunately can have devastating consequences, when in reality, in some cases, it's curable. In many cases, it can be curable. So for example, I've had patients who had unilateral adrenalectomy and came off of all their blood pressure agents. And that's really, really profound and really cool. So that's my takeaway. And if it can start earlier before it reaches us, that would be even better. And there are some countries, even in Asia and Japan, and some Chinese healthcare systems that actually start screening for primary aldo at the time of hypertension diagnosis. So really, like from the very beginning, when the patient is first diagnosed with blood pressure, they screen for this. And I think that's some good food for thought to leave this podcast and this kind of session off on, because I wonder, had we tested it for more and more people on the earlier side, would we have prevented a lot of these morbidity and mortalities? Yeah.
Thank you both so much for broadening our illness script. I think many more people will be screening for secondary causes of hypertension after listening to this. And I also wanted to say that I don't think we've ever had a guest who includes this much data so seamlessly into their teaching, and I absolutely love that, and that is my goal in general, to be that way. So thank you both so much, and thank you for everyone who joined today.
I appreciate the time.
Thanks so much.